All right, don't panic yet. I know we talked about the clinical presentation and it seems like a lot of information, but getting that foundation is important in allowing you to answer the rest of the question because that's the foundation. So let's put this aside and talk about rate and rhythm diseases. In rate and rhythm diseases, we're talking about the arrhythmias. Here we have conductive system. We will talk about some of the conductive system pathway, the disease in the nodes of the heart, ventricular arrhythmia, supraventricular arrhythmia, and then some management options. Let's go over the conducting system here. As you can see here, there's an SA node, and there's a travel of electrical activity that goes to the AV node, goes to the bundle of His, to the bundle branches, and to the Purkinje fibers. This is how you should envision when you think about conductive system diseases. When we say something that's before the bundle, think about the bundle sitting right here in the septum. It's pre-bundle versus post-bundle. And when we say left and right bundle branches block, think about these branches here that are going to the left and to the right of the heart. The nodal diseases, we know that the SA node, which is the pacemaker of the heart, means that it controls the pace of the electrical activity of the heart. Then we have the AV node, which essentially is the slowest part in terms of the pacing. So therefore, it also has a major control of the conductivity of the heart. Then we will go over some pathology images here. Let's talk about the SA node. In the SA node disease, the most common etiology is a person who has an excessive vagal tone. Something is causing an overstimulation of the vagus nerve, which leads to an excessive vagus tone. Now remember, the heart is under parasympathetic control. Vagus nerve is a parasympathetic nerve which controls the activity of the heart, meaning the SA node. If you inhibit the parasympathetic component, sympathetics takes over. If you lead to excessive parasympathetics, then you slow down the heart rate because again, that's parasympathetics. So excessive vagal tone in situations such as giving a person digitalis, vagal maneuver, acute myocardial infarction, doing a carotid sinus massage, all of those things increases the parasympathetics, which slows down the heart. On the other hand, you may have a physiologic component of this where a person who is an athlete, especially those who are marathon runners or swimmers, will have more stimulation on the vagus nerve. Therefore, their overall resting heart rate is a little bit lower than most folks. Then you have certain disorders and medications which may also affect the SA node. You have endocrine pathology, STAR. Endocrine pathology that deals with hypo versus hyperthyroidism can cause a direct effect on the SA node. In the case of hypothyroidism, again, a direct effect on the SA node will slow down the heart rate. Hyperthyroidism, a direct effect on the SA node will inhibit it, thus inadvertently increasing the heart rate. On the other hand, you have depression of the SA node with things like beta blockers and calcium channel blockers are also important medications to remember. Clinical presentation for SA node pathology will be things like sinus bradycardia and a heart rate less than 60 beats per minute. Again, recall from the previous video, we said that the heart rate 60 beats per minute is bradycardia, 90 beats per minute and above is tachycardia. Management for SA node pathology, you essentially want to do atropine versus pacemaker. Depends on the clinical vignette. The first line of treatment is to give atropine. You give atropine first, but if you think this is a major pathology, it's severe enough, then you have to do intracardial pacing. In a case where this person excessive increase in the vagal tone is due to a beta blocker overdose, your drug of choice is glucagon. Now, if you are thinking about a way to find a simple roadmap in terms of which drugs to give first, you will first think about giving atropine, then you will think about giving the patient glucagon, then you may think about doing intracardial pacing. So pacing is almost seems like the last result, but glucagon should be given first when you think the person has a beta blocker overdose. Then you go to the AV node. An effect on the AV node can slow down the heart rate as well. The thing here to remember are the first degree heart block, the second degree heart block, and the third degree. First degree is very straightforward. Second degree is where the bulk of your questions will come from. Let's talk about first degree. In the first degree heart block, the most common etiology is that the person who is aging, they have digitalis intoxication, they have cardiomyopathy, or they have ischemia. Essentially what's happening is that this individual has a prolongation of the PR interval. PR interval is fixed prolonged. Usually it should be less than 200 milliseconds. But in the case where the PR interval looks like it's more than two of those small boxes, that's more than 200 milliseconds, you know it's prolonged, and you know that this person likely has a first degree heart block. In terms of the management, you really do nothing for first degree heart block because in most cases, it doesn't lead to anything major. Second degree heart block is where the bulk of your questions will come from. In this case here, we have two different types of second degree heart block. We have Morbus type 1 and Morbus type 2. Morbus type 1 is called a Wenckebach pathology, and Wenckebach is pre-Heinsian or supra-Heinsian. Recall from that image we show the bundle of His, which is the supra-Heinsians we're talking about here. So above the bundle of His, that's where the Morbus type 1 likes to take place. The pathophysiology is that the person may have a prolongation of the PR interval, but it is a progressive prolongation. So first it is this long, then it becomes this long, then it becomes this long, then it becomes this long. And eventually it gets so long that it interrupts the ventricular depolarization and it leads to drop of the QRS complex. That is the main thing to get. Progressive prolongation of the PR interval with an eventual drop of the QRS complex. Then the key thing to really note that this person is dealing with Morbus type 1 is that immediately after the progressive drop of the QRS complex, you see that the PR interval comes back to normal. So that is your goal mind. Once you can see the PR interval comes back to normal, then you know you're dealing with Morbus type 1. You give an individual atrial pain, it will shorten the PR interval, and that will lead to an increase in the AV conductivity. So you know, okay, this person specifically has Morbus type 1. You can do carotid sinus massage. It will also lead to increase in the blockade. Again, that's overstimulation of the vagal nerve, increasing the vagal tone, which will lead to blockade of the heart. This individual also has what is called the Adams-Stoke. This can be seen in second degree heart block in both Morbus type 1, Morbus type 2, can also be seen in third degree heart block. Adams-Stoke is when a person simultaneously gets a fainting spell with no warning whatsoever. The difference here is that we need to be able to compare or contrast Adams-Stoke from things like syncope and actual stroke or seizures. So seizures, syncope, and actual stroke. Adams-Stoke, you will think this person has some kind of a heart block and they suddenly pass out. Syncope is completely different. Stroke is completely different. That's all the way in neurology, right? And then seizure is also in neurology. The person has specific signs and symptoms. Things like post-tactile state will clue you into seizures. So let's move on and talk about Morbus type 2. In Morbus type 2, we said this is infra-Heinsian, meaning that it's below the bundle of His. And the pathophysiology for this is that the individual will have a prolonged or fixed PR interval. The PR interval may either be long or short, but whatever it presents with, that will be fixed. And the individual will have a widened QRS complex with an eventual drop of the QRS complex. So if the PR interval is fixed, it will be this way, this way, this way, drop of the QRS complex. Then complication again, Adams-Stoke, which the person may have sudden signs and symptoms of fainting without any warning, and that's usually secondary to cardiovascular arrest. So Morbus type 2, fixed PR interval with an eventual drop of the QRS complex. Move on. Then we have third degree heart block, essentially where there's a complete disarray between the ventricles and the atrium. The pathophysiology for third degree heart block is that all the atrial beat will be blocked, and it seems like it has skipped some kind of a conductivity pathway, and the ventricle will continue to beat on. So therefore, you have complete disarray between the atrium and the ventricles. The etiology for third degree block is very classic. One of the first one is called the Lindgren's disease. This is when you have scars and soft tissues within the heart, and you have this fibrosis or degenerative cardio muscle tissues that turns into like collagen type 1, and that prevents any conductivity from going through it. It's mostly seen in a person who has a history of MI. Then you have infection, which can cause third degree heart block, secondary to abscesses and maybe a person with myocarditis. Then you have digitalis and or people who have an ankylosing spondylitis type problem. All of this is saying that something is interfering with the conductivity system that completely separated the electrical activity from the atrium to the ventricles. So they have complete disarray in third degree block. Third, we say in terms of the clinical presentation, patient may present with signs and symptoms of Adams-Stoke, which we just talked about. In terms of management for third degree heart block, cardiac pacing. Because it is so severe, it is in complete disarray between the atrium and the ventricle, you gotta do cardiac pacing. In pathology, we have these different images to master, because in most cases of the heart blocks, they will give you an EKG image. In most question of the heart block, they will give you an image of the EKG. So let's look at the image here. In this image here, you can see that the patient has a fixed presentation of the PR interval. This is too long. This is also too long. And because of how long it is, you know this person is experiencing a first degree heart block. On the second hand, we have second degree heart block, which we have Morbus type 1 and Morbus type 2. Here you can see that the PR interval here is not as long. It looks normal here. And then it becomes a little bit longer, and then it becomes a little more longer. And then before you know it, there's an eventual drop of the QRS complex, and then it is back to normal. So if you look at this one here and compare it to this one here, they're about the same. That's Morbius type 1. In Morbius type 2, we have this PR interval, which is actually fixed normal. It looks normal. It doesn't look too prolonged. Maybe it's prolonged, but it's fixed. So you can see it's fixed here, it's fixed here, it's fixed here, and then there's an eventual drop of the QRS complex. And this here is the same as this, as well as this, as well as this, because they're all fixed the same. There's a second subset of Morbius type 2 in where the person may have a specific ratio of 2:1. Here you see that the interval is here, is fixed, maybe a little bit prolonged or normal, and you see there's a drop of the QRS complex, and then you see that it is fixed here and there's a drop of the QRS complex. The 2:1 indicate that you see these two peaks, the 2:1 indicates that you see this here, the P wave, another P wave, and the QRS complex. So P wave, another P wave, and the QRS complex. So there's 2 P wave to 1 QRS complex. Then you have the third degree Hart block in where you see here, now you can see the QRS complex, you can see a P wave, you can see a P wave here, there's no QRS complex here, and after this P wave, there's a fixed, prolonged, and you see a QRS complex, there's a complete disarray here. There's no order to this. That's third degree Hart block.